Ready?
Yes.
All good. All right. Good morning, everyone. This is Mark Arnold, Senior Vice President of Marketing here at Zap Surgical. Welcome and thank you to everyone for joining us today for what is our 5th webinar in a series of 10 talks over 10 weeks. So being the 5th talk of 10, we have 5 more in store for you. The 5 that you see on your screen there on the right. I encourage everyone to go to the SRS webinar series website, and the URL is up there in the upper right-hand corner. To see what other talks we have in store for you. And also on this website, you can find links to view recordings of select previous webinars that we've held. And one last item of business before we get started. If you'd like to submit any text written questions, you can do that using the Q&A button that's in your Zoom console. I've highlighted it there. That's what it looks like on my screen. It may look a little different on your screen. But time permitting, Dr. Sheehan will address your questions at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical. He's also Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Over to you, Dr. Adler.
Thank you, Mark. And welcome, everybody. We've had a wonderful series of webinars the last few weeks, and I'm delighted that you could join us today, brought to you by Zap, and coincidentally, or not so coincidentally, and somewhat tragically, by COVID-19. Today, I'm excited, really exhilarated to present Jason Sheehan. Jason, who is, I consider a friend and a colleague for the last couple of decades, is Neuroscience and co-director for the Lars Leksell Gamma Knife Center at Charlottesville and University of Virginia. And he's also a chair professor in neurosurgery and as well radiation oncology. And I'm just delighted to have him be able to speak to us today. His talk is going to be titled "Brain Mets: Dispelling Myths and Focusing on Facts." So, Jason, facts and myths that we need to be more aware of.
Yes. Well, I want to thank you and Zap for inviting me to speak. And obviously, I think that these webinars. Yes. Yes, I think that these webinars are very innovative as well as very important during this COVID time. So I'd like to speak today about an important topic in the field of radiosurgery, the notion of how to treat brain metastasis with radiosurgery. Really, what are some of the myths that are out there about brain metastasis management, and what are the facts that we have at hand? So, next slide. The second slide indicates the epidemiology of brain metastasis. And as you no doubt note, cancer in ordinary times is one of the leading causes of death, and its likelihood of metastasizing to the brain is quite high for the major tumor histologies, including lung, breast, melanoma, and gastrointestinal cancers. 170 to 300,000 new cases of brain metastasis occur in the United States each year. Median survival, despite best medical and surgical management, still hover around 6 months, although I'll show you that this is not a uniform disease. The next slide. The slide that follows is a slide of a study that was accepted and was recently published in the Journal of Neuro-Oncology. This is a study that looks at the probabilistic map locations of new brain metastasis in a large cohort of patients. Really what this shows in the findings of this study, just published in the Journal of Neuro-Oncology earlier this year, show that the location of brain metastasis is not uniform throughout the brain, and that the cerebellum is overrepresented, that gastrointestinal cancers appears to have a predilection for the cerebellum, whereas breast and lung cancers appear to have a predilection for the frontal lobes. No doubt this is histology dependent to a degree and also affected by cerebrovascular anatomy. And then certainly the milieu varies likely in areas of the brain. So the next slide shows the grading of brain metastasis patients. And I think that probably every year or more often, someone either identifies a new grading system or refines an existing one. There are a number of them out there. Some of the more robust ones are the RPA class and GPA. Also, simply Karnofsky performance status is a valuable tool that neurosurgeons frequently employ to stratify patients with brain metastasis. And certainly you want to determine what extent of intracranial disease they have, what past treatments they've had, what their overall extracranial disease state is, and what symptoms they have. And you've got to factor all those into making a informed set of recommendations for the patient in terms of treatment options. The next slide shows the one of those grading systems, the disease-specific GPA and survival. And as you can see here, and circled in red, that some of the survivals, for instance, with non-small cell lung cancer and EGFR or ALK mutations, that median survivals can be nearly 4 years, as compared to, for instance, those that may have disease-specific GPAs of 0 to 1.0 for non-small cell lung cancer. Their expected survivals may be 3 months or less. And so some of these individuals, as shown here, particularly in the circled red columns, have a relatively almost chronic state to their underlying metastatic cancer, as compared to some that have a very short life expectancy based upon aggressive underlying tumor histology and widespread disease and poor performance status. So we do not want to treat all of these patients equally. Some are going to inevitably do better and more innovative and targeted treatments. So let me move on to the next slide. Historically, when I was a resident and you were called about a patient with a brain metastasis, the treatment algorithm was rather simple. If they had a solitary brain metastasis, you would resect it and then perhaps treat it with radiation therapy thereafter. And if they had multiple ones, you would send them for whole brain radiation therapy. Next slide. The whole brain radiation therapy outcomes haven't changed much in the last 3 to 4 decades. If you go back to the 1970s, the standard 30 gray and 10 fractions afforded a median survival for all brain metastasis patients of about 21 weeks. And that there really isn't any evidence to support new fractionation schemes or schedules or doses as really having an impact upon survival for brain metastasis patients who are receiving whole brain radiation therapy. Next slide. There was a more recent study that was called the Court study that randomized patients to whole brain radiation therapy, 20 gray and 5 fractions versus best supportive care. Interestingly, in the modern era, for these patients who had a predominantly poor performance status, that the very patients that we tend to use whole brain radiation therapy for, that there was no difference in the quality adjusted life years or overall survival with the addition of whole brain radiation therapy over best supportive care, again, in a more modern era. The next slide. The Court study concluded, if you'll hit the mouse perhaps, concluded by saying that whole brain radiation therapy did not appear to offer substantial benefits to patients with brain metastasis with non-small cell lung cancer. And it does sort of beg the question of whether or not we should be reevaluating the role of whole brain radiation therapy in the modern era with better supportive cares and better targeted therapies. Next slide, please. There was another recent study published by a colleague of mine, Dan Trifoletti at Mayo, who publishes just earlier this year, looking at differences, again, between 30 gray and 10 and 37.5 gray and 15 fractions. And as is true for many of the other studies shown, and this is a more modern one, looking at a higher dose and more fractions, there was really no benefit in terms of cognitive deficit, tumor control, or overall survival. So 30 gray and 10, or 20 gray and 5, or 37.5 gray and 15 all appear to confer about the same degree of benefit for patients with whole brain radiation therapy. Next slide. So what are the side effects of whole brain radiation therapy? Next slide. We published a study in the International Journal of Radiation Oncology and Biological Physics grading the leukoencephalopathies that arose after patients receiving radiosurgery and or whole brain radiation therapy. Next slide. This color-coded graph shows the difference at baseline, 1 year, 2 years, 3 years, and 4 years. The orange and yellow are the higher grade leukoencephalopathies. And it's clear that patients who had whole brain radiation therapy in addition to radiosurgery were much more likely to develop high-grade leukoencephalopathies as a function of time. It's not to say that patients who had radiosurgery alone couldn't, but they were far less likely to develop them. The real breakdown, next slide, was around the integral dose to the skull. If you delivered more than 3 joules, or 3 or more joules to the entire head, you were likely to develop a high-grade leukoencephalopathy. And that's not really much when you think about the doses and the energy that's given over a standard 30 and 10 gray fractionation scheme. Most of those patients are going to be at high risk for leukoencephalopathy, and the accompanying changes, likely many behavioral and neurocognitive, that happen. As you can see, it's a 3-year time point. Next slide. Eric Chang published a very important paper now nearly a decade ago that showed that with radiosurgery alone as compared to radiosurgery plus whole brain radiation therapy, that radiosurgery alone patients were far less likely to develop neurocognitive deficits, specifically around learning and memory dysfunction at the 4-month time point. Another study, next slide, published more recently by Paul Brown, the N0574 study, next slide, stratified patients again with, if you hit the mouse, whole brain radiation therapy and radiosurgery versus radiosurgery alone, and found a statistically different outcome at 3 months with less cognitive progression in the radiosurgery arm alone. If you'll hit that, this deficit persisted at 6 months, if you'll hit the mouse. And let's go on to the next slide. Overall survival was not statistically different, although was favoring radiosurgery alone, as shown on this slide in the N0574 study. But again, no difference in overall survival, but clearly a difference in cognitive function. Next slide. Some of the innovative things that have been done around hippocampal sparing, and that's on the next slide. The hippocampal sparing whole brain radiation therapy, as shown here, has been shown to lessen the risk of decline of Hopkins verbal learning scores and other cognitive assessments. Really what you're doing is carving out around the hippocampus and amygdala those structures and avoiding any appreciable amount of radiation as you give the whole brain. You can also give memantine. Next slide. And what this study showed with hippocampal sparing whole brain radiation therapy was that, similar to memantine, that the cognitive failure rate was reduced at 4 months, but that rate of decline was still greater than 50%. Next slide. Certainly the overall memory structures are much more intricate than hippocampus and amygdala alone. Next slide. Interestingly, when you look at the costs of hippocampal sparing whole brain radiation therapy, as shown here on the right in red, hippocampal sparing whole brain radiation therapy costs to CMS in 2014 per case were greater than they were for radiosurgery, which sort of begs the question of if patients have limited intracranial disease and you wanted to preserve neurocognition, why not consider radiosurgery over whole brain radiation therapy with hippocampal sparing? Next slide. We did a meta-analysis that was published last year that showed that the rate of cognitive decline, if you look across multiple studies, was lower for patients who had radiosurgery over hippocampal sparing, whole brain radiation therapy, or whole brain radiation therapy with memantine. Next slide. So what are some of the myths? Let's go on to the next slide. I'm oftentimes asked, and as I'm sure Dr. Adler is and others, what's the cutoff? How many brain metastases is too much to treat with radiosurgery? Keep in mind that most radiosurgical platforms, be it ZAP or others out there, have the flexibility and the robustness to treat multiple brain metastases in a single session. So next slide. The number of lesions is probably less relevant than the actual volume of metastatic disease in the brain, so that on the left picture, 0.1 cc tiny metastasis are probably not as much of a concern as someone who has a 1 met that's 5 cc's in size. Again, volume is probably the determinant, as shown next slide, in a paper nearly 15 years ago that by the Pittsburgh group that has since been replicated by a number of other centers, showing that volume more than, if you hit the mouse, volume more than number is a major determinant in outcomes for overall survival and for adverse effects after radiosurgery for patients with multiple metastases. Next slide. This was shown again in 2014, and here's some cutoffs, but really when you start to get above 10 cc's, you begin to start to have a diminished overall survival in terms of total intracranial disease related to metastasis. Next slide. And in fact, the National Comprehensive Cancer Network did indicate that it wasn't really number, but volume here as shown in their guidelines that should be a determinant in whether or not someone should get radiosurgery. Obviously, they also note performance status. Next slide. Another myth is that metastases are everywhere. And as the video shows, this is a tail vein injection of cancer cells, shown here in red. The cancer cells go up into the brain and circulate into the microvasculature, but you'll see that very few of those cancer cells actually go on to form metastatic lesions. So that not every instance of a cancer cell getting into the brain forms a metastasis. And in fact, that many small metastases can be watched and don't necessarily need to be treated. So it's only the green lesions shown in that video that go on to form actual demonstrable metastasis. The red ones are lesions that didn't take. The milieu wasn't hospitable to that metastatic lesion forming. So intervene when appropriate. Next slide. So the micrometastases really require an appropriate upregulation and change in their tumor cell biology. Some of this has to do with the GFAP expression locally, the local expression of cytokines, the vascular permeability to allow the metastatic cancer cells to get across the microvasculature of the brain. And in fact, this study by Schwartz in 2016 really showed that micrometastasis formed infrequently and in a minority of instances where there was evidence of cancer spread across leaky blood vessels in a mouse model. So next slide. The other point in myth is that some of my colleagues have is that we need to treat every metastatic lesion. And at this present point, I would say that that's not really required for every patient. Some metastatic lesions are asymptomatic and can be followed. Of course, a number of studies have shown that there's a disconnect between intracranial disease control and overall survival. And keep in mind that for many of these patients, that we're not curing them and that our interventions are palliative. Never less important, but palliative. Next slide. The idea of all patients that get whole brain radiation therapy suffering neurocognitive decline is also not well founded in the literature. In fact, a minority of patients, for the most part, develop any appreciable neurocognitive decline beyond those tests that we oftentimes perform that don't necessarily always have real-world ramifications. But considering newer techniques, we can, such as hippocampal sparing, radiation therapy, or memantine, we can limit some of the neurocognitive decline that happens in patients. Obviously, for patients who are expected to be longer-term survivors beyond a year, that we need to look more closely at the use of whole brain radiation therapy in those sorts of patients. Next slide. You know, I'm at the University of Virginia, and we hold Thomas Jefferson near and dear to our hearts. And this idea that all individuals are created equal may be true for man, but it certainly is not true for brain metastasis. Outcomes vary tremendously amongst brain metastasis patients based upon type of cancer, histology, subtype, and genetic subtypes. And that we certainly need to appropriately stratify patients. And as I've shown you, there are a number of different tools to do that. Next slide. There is also an idea that a myth that radiosurgery is deleterious or may not be needed with immunotherapy or targeted therapy when given to patients. And let's look at the targeted therapies and immunotherapies and the differences here. But really what you can see in red is that, yes, targeted therapies can have a fairly rapid effect upon tumors and occasionally can be curative. Immunotherapies tend to be slower onset. As soon as you discontinue the drug, there's recurrence. The idea of using these therapies, next slide, is being tested in patients without radiosurgery, in largely patients who are asymptomatic and have smaller metastatic lesions. So in this study published in Lancet Oncology in 2016, they reported their outcomes for patients who had asymptomatic lesions that were 5 to 20 millimeters in size. The median was about 1 centimeter in size, and these patients received Pembro every 2 weeks. The overall response rate was 22% for melanoma, 33% for non-small cell lung cancer. 17% of patients that had melanoma developed seizures, and no lesions that failed radiosurgery or whole brain radiation therapy, interestingly, before the Pembro was given, responded to Pembro. Next slide. So if we look at across the board some of the studies, for instance, for immunotherapies for melanoma, control rates vary, if you push the mouse, between 6.7 and 90%, but that they're generally, for asymptomatic small lesions, under 50%. Next slide. So can, in fact, immunotherapy replace radiation or radiosurgery in melanoma brain metastasis? And I've highlighted a section here from this article in Journal of Clinical Oncology published in 2019. But the idea of delaying radiosurgery, I think, is largely not appropriate if you think that the patient is going to have a expected survival of more than 6 months. Let's be clear that the response rates for immunotherapies hovering between 25 to 50% do not equate to the typical local progression-free survivals achieved with radiosurgery between 80 to 90%. Next slide. Interestingly, there's been some discussion about in this recent published paper earlier this year about what should come first. Should the immunotherapy or checkpoint inhibitors be done before radiosurgery or afterwards? And in this study, they looked at the upregulation of apoptosis genes, 48 genes, and found that giving ionizing radiation in this mouse model of metastatic cancer before immunotherapy upregulated or deregulated apoptosis genes much more effectively than giving immunotherapy and then giving radiation therapy. So if we want the underlying cancer cells in the brain to respond to and to proceed to apoptotic cell death, it would seem intuitive based upon this gene expression study to give radiation or radiosurgery before immunotherapy. Next slide. Here's another meta-analysis that was done and we published that looked at that immune checkpoint inhibitors. And what we concluded was that the overall risk of radionecrosis was 5.3% in patients who had radiosurgery while they were on immune checkpoint inhibitors, and that this was a acceptable and generally manageable rate of radionecrosis, so that we should not be fearful that by giving ionizing radiation when giving concurrent checkpoint inhibitors, that we are going to be causing appreciable adverse effects in most patients. Next slide. And this is really just looking at the local tumor control rates at 1 year out across a number of those series in that meta-analysis. Next slide. In some fields, this may be heresy, but what I'm about to say is that this myth of single session radiosurgery is always better. This was published in, this study that I'm highlighting was published in 2016, but a number of other studies have shown that in instances where the metastatic lesions are smaller, the tumor where they're larger, or the tumor volume may be ill-defined, such as an irregular resection cavity, that hypofractionating radiosurgery may actually be advantageous for overall local tumor control. Next slide. Certainly, another myth is that radiosurgery can only be used for patients who have brain metastasis under 3 centimeters in size. Increasingly, we are seeing, and certainly even in the COVID era, where patients, perhaps were not able to get access to craniotomies in quite as timely of a fashion, the use of hypofractionation for treating larger brain metastasis can and should be offered for select patients. You can fractionate patients in a staged fashion, separated by 2 to 4 weeks, treating the entire metastatic lesion, or you can give small portions of the metastatic lesion, a larger lesion. You can treat those portions sequentially by volume. Next slide. And this is just an example of a paper by Dr. Yamamoto that summarizes 2 or 3 stage radiosurgery for patients with larger brain metastasis. It's very clear that these patients could not be treated as safely or as effectively with single session radiosurgery, but can be treated with 2 or 3 stage radiosurgery much more effectively. Next slide. So here's an example of a patient that was treated with hypofractionated radiosurgery. And you can see the large metastatic lesion in the left temporal region and gradual reduction in size. Dose fractionation schemes vary widely. Some that we've used at the University of Virginia include 8 gray times 3 or 5 to 6 gray times 5. Next slide. And then I'd like to point out that there are some guidelines that are out there that can help to lead clinical decision-making. These should not be viewed in a rigid fashion, but the CNS published brain metastasis guidelines that show what favors radiosurgery: generally smaller volume, fewer lesions, better performance status, radio-resistant tumor histologies, and absence of leptomeningeal spread, and whole brain radiation therapy: larger intracranial metastatic volume, poor performance, radiosensitive tumor histologies, and leptomeningeal spread at the time of brain metastasis diagnosis. Next slide. So I'd like to conclude by saying that neurosurgeons are playing a larger role ever in the management of brain metastasis patients, that radiosurgery is playing an expanded role either in single session or hypofractionated fashions for patients with multiple brain metastasis, certainly far more than 3 or 5, that whole brain radiation therapy should be used selectively and carefully. Interestingly, radiosurgery can be used after failed whole brain radiation therapy, and I've done that not infrequently with a low risk of toxicity. And then there's an expanded role for chemotherapies, immunotherapies, and targeted therapies, and that we should not be hesitant to use radiosurgery in conjunction with these newer emerging medical therapies, and that the two actually seem to work almost synergistically in many instances with a low risk of adverse events. So next slide. I'd just like to conclude by thanking ZAP, and I'm happy to answer any questions.
Stand by for 1 second, Jason. Dr. Adler, can we unmute you? No, Dr. Adler dropped off. If there are any questions, you can submit typewritten questions using the Q&A button on your Zoom menu. Dr. Sheehan, at this time, there are no additional questions.
Well, obviously my email is readily accessible through my hospital website. Feel free to contact me, and I hope that this webinar has proven informative. And I again commend ZAP for providing high quality educational initiatives like this during these challenging times. Thank you.
So, Dr. Sheehan, we just got 2 questions.
Okay.
Yeah, all right. Why do you think the order of immuno and RADS affects outcome?
That's an interesting question. And I did show that preclinical model was a mouse model of metastatic disease, and where they saw a upregulation of apoptotic genes when radiation was given before immunotherapy as compared to the reverse order. So I do think that you're setting up a cascading of gene upregulation of apoptotic genes that will lead to metastatic cancer cell deaths when giving radiation beforehand. It's also very clear from some studies, ones that we've published as well as other groups, that you want to, if you are going to be giving some of these targeted therapies or immunotherapies, that they should be given almost concurrently. That is, shortly after giving the radiation, you wish to initiate the patient on therapy, and that excessive delays between the two is not to the patient's advantage in most instances. But I think it's probably more again related to the cascading of gene upregulation that leads to that arises from the delivery of radiation beforehand.
Very good. Dr. Adler, you're back.
Yeah, I don't know. I'm in the middle of Silicon Valley, but sometimes our internet connections are not what they should be, I guess. Well, I apologize for.
No, that's fine. There was another question, I think. Were there 2?
Yes.
Dr. Adler, do you see them, or should I present the question?
I'm just kind of catching up. So why don't you present the question, then I'll ask my own then.
So what's a reasonable cutoff volume for SRS? If it's dictated by normal brain volume or measure of dose gradient, how would you decide?
Well, I think for single session radiosurgery, that as one of the studies that I showed was indicated, the Gandhi report, I believe, was that 10 cc's was probably a cutoff in terms of overall outcome. However, I think it's important to understand that when you're hypofractionating, I think you're able to treat larger volumes. And I also know that when we treat resection cavities, that it's not really that the treatment volume per se is probably not, we shouldn't be measuring it, because in many instances, we are measuring cavity volume. And that's not really what poses a risk to patients. If you're dumping dose into a resection cavity, which is largely filled with some residual blood products and CSF, that's probably not as risky as if you were delivering that same dose to an intact solid brain metastasis and then to adjacent brain tissue or brain parenchyma around it. So I think 10 cc's is probably a reasonable cutoff for single session radiosurgery, but that you have much greater latitude with hypofractionation.
Jason, as you know, leptomeningeal spread is a common problem after resection of brain mets. And one of the criticisms of radiosurgery for managing such cases is that it has not to date necessarily prevented leptomeningeal spread. Are there any strategies to be thought about that we are not practicing today commonly to help in that situation? There are different dosing, different targeting schemes. Any thoughts and suggestions?
Well, I think there's been some interesting work that talks about pre-resection radiosurgery as a means of preventing leptomeningeal spread. And that's come out of the Emory group and the Carolina group. And then there has been some innovative work around really what it should be the target volume after resection. And in some instances, I think we may be inadequately providing a margin or really appropriately defining the target volume after a prior resection. So that these are instances where perhaps a high degree of conformalities that we may wish to achieve with, for instance, pituitary adenomas or acoustic neuromas, is not necessarily to the patient's advantage. So that by having a little bit more of a margin on those cases, that we may be able to decrease the risk of leptomeningeal spread in patients who have had a larger metastasis resected and didn't have pre-resection radiosurgery. I do think, too, that the earlier initiation of chemotherapies, particularly the modern ones, immunotherapies and targeted therapies, are really going to be helping us to at least push the extent of leptomeningeal spread and disease progression further down the road for patients. But there's no magic answer, and it still remains a risk. Certain histologies, of course, are at greater risk for that. You know, your classic concerns, of course, around some of the triple negative breast cancer patients.
You made a declaration during your talk that some mets are small and asymptomatic and should not necessarily need to be treated. How do you know? And in many respects, isn't it maybe just easier to treat and forget? I kind of appreciate the fact that there may be circumstances where you wouldn't want to treat. Maybe a patient's about to die from other causes, but why not, if you see a met and it's simple to treat, just treat it?
Well, it's an excellent question, and I participated in a study several years ago with others and leading folks around in the community, where we were given a description of about 30 patients and then asked to project what their expected survival was. And interestingly, neurosurgeons and neuro-oncologists and radiation oncologists all did uniformly pretty poorly at predicting them based upon all the things I've just told you are important factors used for the various grading schemes. So you're correct that we don't do a great job and don't know how to predict who's going to be long-term survivors, but increasingly we're doing a better job of that. The patients that I would favor not treating would really be patients that are asymptomatic and have underlying extracranial disease progression, and are patients who are good patients who are willing to come back or will call you if there's a problem. So if I don't think that someone's going to come back in 6 or 8 weeks for another scan, or they're a non-compliant patient, I agree with you. It's far better to treat that patient's metastatic disease than to watch and wait. But in my health system, we have a multidisciplinary clinic for brain metastasis patients with neuro-oncology and medical oncology and radiation oncology inputs, all given usually on the same day. And if the consensus is that a 3 millimeter metastasis, it can be watched for 6 or 8 weeks, and they're still getting therapies that may have good CNS penetration and for which that metastatic lesion might respond, as I showed you, somewhere between 26 to 50% of the time, it may be worth watching those patients. And I do think we also need to be good stewards of healthcare dollars, and so we don't want to expend them where we're not providing appreciable benefits to the patient. But it's hard to predict with certainty who those patients are that need to be treated versus who can be watched.
I only wish my colleagues operating on spine mets with, $200,000 procedures could show the same constraints sometimes.
I think increasingly we're going to be looked upon, as you know, by these challenging times lead to greater expenditures and higher deficits. We're going to have to be looking more carefully at our healthcare expenditures.
But I've been humbled on many occasions by totally misjudging the life expectancy of a given patient, either too little or too much.
Agreed.
In the course of my career. So, Mark, do we have time for one more question, or where do we stand?
We do. We have time for one more question.
So, in terms of, we're seeing more and more patients, Jason, who are coming back year after year with multiple Mets, and sometimes larger Mets, and obviously going to get cross that threshold of ever greater number of jewels to the skull, as you were describing. And so, in the effort to kind of preserve brain function and minimize leukoencephalopathy, are there strategies? I'm intrigued about, is fractionation going to be part of that strategy? Is memantidine? If this is going to be a chronic disease, we obviously want to keep people's cognitive function at the highest possible level. So those patients who are going to come back year after year, any strategies for keeping them cognitively intact?
Well, I think that we need to be looking at, increasingly, there are going to be cohorts of patients that are going to be battling metastatic cancer, melanoma, breast, and lung, who are going to be long-term survivors. And that's been shown in some of the early slides I indicated in my talk, with median survivals in subgroups of patients that are nearly 4 years. That's median survival. So, and I know that you've had, and I've had, some 5 and 10-year brain metastasis survivors that continue to work and continue to be high functioning. So where we need to help those patients is going to be as precise and accurate in delivery of ionizing radiation, looking at the integral dose, looking at the outlying doses to normal brain tissue, and then considering the use of fractionation into patients where it really makes sense in terms of, for instance, a metastatic lesion that may be close to an eloquent region of the brain. And I do think that there's going to be more elegant use of functional imaging and tractography, where we'll have a better understanding, much as we do with open operations, about what tracks to avoid if we're going to do a surgical approach for resection, what tracks beyond optic nerves, for instance, and optic radiations, but what tracks, for instance, that may involve language or memory or vision, or cortical spinal pathways, what their tolerances are for ionizing radiation in single or hypofractionated fashions with radiosurgery. So we've got to maximize the quality of life of patients, not just their life expectancy, and that if patients have a poor quality of life but are living longer, that's not necessarily what patients want. So I agree, medical and technological approaches, as you and others have done, in refining the radiosurgical platforms, is really going to be one approach to minimizing risks and maximizing benefits for patients.
So, any role for memantidine in radiosurgery patients?
I think that there could be. We've used it. It's expensive. We have used. I know some insurance companies will not cover it for whole brain radiation therapy, believe it or not, despite the evidence. But I think there is a role for it, and I also think that there are roles for some other drugs that are in trials, but it's premature to say just what values they may have in terms of neuroprotection when giving radiation. But I do think that I've explored one, and in my lab, it's currently being pursued in a randomized controlled trial for stroke, but it did show some ability for radiosensitization, as well as potential radioprotection of other surrounding tissues. So I think there's a lot of mechanism by which we can leverage biology to help to protect the brain.
Perfect.
Thank you.
Okay. Well, thank you, Jason. That was really a great survey of kind of the leading edge radiosurgical treatment of brain mets today. And I know I learned a lot, and I'm sure others in the audience as well, feel similarly. So if any of you have additional questions, you feel free to forward them to Mark or myself in the coming days, and we might pass them on to Jason if we don't answer them ourselves. But I appreciate you, Jason, speaking to this audience this morning. And I appreciate the audience itself for showing up and joining our little COVID webinar series. So thank you all, and look forward to. So Mark, did you some last minutes? You want to give a last shout out to upcoming webinars?
Oh, wow. Okay. Yes, next week we have Dr. Sorensen from Barrow, who will be presenting on dosimetry using his vault-free radiosurgery system, which of course is ZapX. And we have a couple of other interesting talks in the queue. I would direct folks to srs-webinars.com. And then one last shout out, a little insider information. This was 10 talks over 10 weeks. We're probably going to extend this by an additional 5 talks. So stand by, more information will be forthcoming. We've got a lot more great information coming your way.
Thank you so much.
Thank you.
Thanks, Jason. Okay.
Have a
Bye-bye.
great day.
Be
Bye-bye.
safe, everyone. Bye-bye.